Discussion on echocardiogram in ventricular septal defect. Parasternal long axis view shows the subaortic perimembranous ventricular septal aneurysm marked by arrows. There is a small ventricular septal defect at the apex of the aneurysm which is not very clear in the 2D image. Please subscribe to this channel for future updates. Click on the subscribe button. Press the bell icon after that for all updates. Right panel shows the mosaic VSD jet from the apex of the aneurysm into the right ventricle. Other structures seen in the image are the aorta, left ventricle and the left atrium. Mitral valve is in the closed position as it is a systolic frame. Echocardiogram in a tilted apical 4-chamber view showing all 4 cardiac chambers. RA right atrium, RV right ventricle, LA left atrium, LV left ventricle. The perimembranous ventricular septal aneurysm with defect is marked by arrow in the left panel. Right panel shows the reddish mosaic multicolored jet through the ventricular septal defect. Continuous wave Doppler interrogation of the ventricular septal defect showed a pansystolic jet with a peak gradient of 61 mm of mercury. This will be the difference between the systolic pressures of LV and RV. In a large VSD, when the pressures in the two ventricles are nearly equal, the velocity of the VSD jet will be small and hence the gradient will be low. When the pressure gradient across the VSD is high, it usually means that the VSD is restrictive. Here it is a restrictive VSD. Sometimes the right coronary cusp prolapse can cause aortic regurgitation even in a restrictive VSD. This echocardiogram in apical 5-chamber view shows the mosaic multicolored jet of a small ventricular septal defect near the apex. The cardiac chambers are not dilated. The small defect is difficult to see on 2D echo, though it is easily detected clinically with a pansystolic murmur, and Doppler echo documents the high velocity jet across the VSD. Continuous wave Doppler interrogation shows the interventricular pressure gradient as 81 mm of mercury, which is consistent with a restrictive VSD. Small muscular VSDs like this are likely to close spontaneously on follow-up. They will not cause pulmonary hypertension or heart failure and usually have good prognosis unless complicated by infective endocarditis. Natural history studies have shown that small muscular VSDs have a high likelihood of spontaneous closure. Spontaneous closure occurred in 76% cases by 12 months of age in one study. But apical defects tend to have a higher persistent patency rate than defects in other locations. P-value less than 0.05. Long-term course of 600 small and moderate muscular VSDs diagnosed over a 6-year period has been reported by Eric L. Shelby-Cutti and associates. They found that though pediatric cardiology follow-up was recommended, these did not result in any significant active medical or surgical management. Of the 316 follow-up visits recommended, only 259 happened, though there were 37 other unplanned follow-up visits. 85% of this cohort had small muscular VSD on initial echocardiogram. Here are a few references on ventricular septal defects. Here is one more reference on the natural history of muscular ventricular septal defect. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.